everybody. Welcome to Prostate Forum of Orange County, California. Um, Tonight's presentation is how to sort through the different prostate cancer biomarker tests and focal therapy, HIFU versus TULSA. Our special presenter tonight is Dr. Jennifer Linehan, MD, Associate Professor of Urology and Urologic Oncology at St. John's Cancer Institute in Santa Monica, California. A bit about Dr. Linehan is a board-certified urologist and professor of urology. She has completed her medical degree in general surgery at University of Arizona. She received her George S. Drock Award, I hope I pronounced that right, for most compassionate urologic resident. She has also received awards for research and diagnosis and management of kidney cancer. She is an experienced robotic and laparoscopic surgeon, and she also conducts research and publishes in areas such as identifying prostate cancer biomarkers. A bit about how we conduct our meeting. Please mute yourself during the presentation and during questions and answers. I will mute myself too, so you don't get background noise. Background noise is a big problem in meetings, and we want to cut it down so we can hear the speaker. Our presenter will go for 45 minutes to an hour. During and after that, you are invited to post your questions and comments in the chat. I will read those questions and comments and our presenter will respond to them. If we need clarification, we'll ask you to unmute and speak directly. This way we have an organized question answer session. We are the Prostate Forum of Orange County. We are a 30-year-old support and information group for prostate cancer patients and their loved ones. We run 2 support groups every month and 11 presentations like the one you're watching now every year. We've saved men's lives and helped thousands of men with their recovery from prostate cancer. You can find out more about us at prostateforum.org. And now, without further ado, I want to present Dr. Jennifer Linehan.
So actually, tonight's talk is just about HIFU versus TULSA, because it would be an incredibly long talk if I did the biomarker talk. But I'm happy to do that at a different time if you want. Those were just kind of some of my ideas that I was happy to kind of go over that I feel like patients have a lot of difficulty with at times because there's so much out there. I mean, shoot, even we have difficulty at times separating out which of the biomarker tests are better. But I think one of the most recent questions I've gotten a lot of is, what are we doing as far as focal therapy with HIFU versus the TULSA Pro? So I was going to kind of go through some of that. Now, I will admit that the data for TULSA Pro is not great because it's not had a chance to actually mature yet as much as the data that we have for cryo or the data that we have for even HIFU at this point. So let me share my screen. This one. And then I will put it in full mode. Slideshow. Okay, can you guys all see that?
Yes.
Okay, so what are the differences really between HIFU and TULSA? Which is one better than the other? And is one preferred for certain types of patients than the other? Is really the questions that are most asked. So we all know that 1990, along comes PSA. And when PSA comes along, we start doing more prostate biopsies because we actually found the numbers going up. And in that time, there was only a single treatment approach. Patients either got radical surgery or they got radiation therapy or XRT. Fast forward to 2020, and now there's a totally different ballgame with how we treat prostate cancers. And it's more based on not only cancer treatment, but also men's quality of life. which back in the 90s, in fact, even back in 2010, when I was at City of Hope, it was more about radical surgery and radical treatments than it was about, quality of life. So now we have non-invasive approaches. Now we have multi-treatment approaches, and now we have focal therapy. So it's more focused on the prostate lesion itself. So what is prostate cancer in the United States? I'm sure you guys already know of some of this because of your prostate cancer group, but there's 30 million PSA tests every year. There's over, I think at this point, 1 million biopsies. There's 180,000 new cases diagnosed every year, and 30,000 of those men will have deaths from prostate cancer. It still is the second number 2 cancer in men. It usually oscillates between lung, colon, and prostate, which is the highest mortality rate for men and which is the most common for men. And we know that there's about 3 million men in America living with prostate cancer. There's probably more. We just don't know. They haven't been diagnosed with prostate cancer. These are patients that have actually been diagnosed. And so we estimate that about 35% of patients, and I would guess even more, are overtreated. What do I mean by overtreatment? Well, originally, when we started out treating prostate cancer, if you had one core on your biopsy of a Gleason 6, which is a very low-grade lesion, you were recommended for radical prostatectomy. Fast forward now, you can have multiple biopsy cores with Gleason's grade 6, even Gleason's grade 7, and be put on active surveillance. In fact, some pathologists and urologists now would even argue that a Gleason's grade 6, which is the score the pathologist gives prostate cancer, shouldn't even be classified as a prostate cancer anymore because it's too low grade. So there's been a huge shift in how we look at prostate cancer and how we treat prostate cancer and what's become more important for the patients. And so now there's much more patients getting what we call either active surveillance or focal therapy than more radical treatments like radiation or prostatectomy. And that's sort of the gradient there. So you can see down here, all these patients really should be anything less than a Gleason 6 or less, especially even some of the patients in a Gleason's 3+4 should be treated with active surveillance, which means you're monitoring the patient. We're not ignoring the fact that there's cancer. You're just checking the PSA every 3 months and following along. Usually you need a biopsy every year, depending on the grade of the cancer. And I often do an MRI too, to follow them to make sure the cancer is not breaking through the capsule. Whereas the higher the Gleason grades go, the more radical I think the treatments get. And so right in here, in sort of this Gleason grade 7, either 3+4 or 4+3, is really where you're looking at doing focal therapy. Now, that being said, I will tell you, I've had many patients come to me and say, look, Dr. Linehan, I want to do the most least invasive treatment that we can do. I understand that I have very high-grade prostate cancer, but I'm only really willing to do HIFU. And I've talked to those patients and said, look, the AUA, the European Society, does not recommend focal therapy, whether that's HIFU, that's cryo, or that's TULSA Pro for high-grade disease. But and they've been like, I understand that, and we've proceeded anyways. So it's not that you can't use those treatments for high-grade disease, it's just not recommended by our urologic societies. Okay. So the place for focal therapy. So what does focal therapy really mean? All it means is in short, is that if you have a prostate here and you have a tumor here and a tumor here, that you're only treating the actual cancer or the actual lesion. So now I have had many cases where, let's say, can you guys see my cursor where I'm circling? Yeah, okay. Let's say I have a patient that has a Gleason 6, which is the pathologic grade that's low grade here. But over here, he has a Gleason 7 or a 4+3. Okay. Now, I know that this Gleason 6 is probably not going to grow. And if that was all that he had, we'd put him on active surveillance. So you might just do a procedure where you only treat the lesion that has the higher grade. That would be the Gleason's grade 7. And you can do that with HIFU, you can do that with cryotherapy, or you can do it with TULSA, or you can, use microwave ablation, but you're only treating the lesion that's right here, that's the higher grade lesion. And so when you're treating the lesions like that, you are helping to spare the nerves around the prostate, prolong the erection, and then you're staying farther away from the urethra, the P channel, so you're less likely to have incontinence. And of course, that the patients that have better quality of life outcomes, so to speak, urinary and sexual function. Hold on, I gotta just move this out of the way. So that's one way that you can use focal therapy to treat multifocal tumors. Now, obviously, if you have a unifocal tumor, which is about 25% of all of the biopsies that we get, then you can just treat that lesion itself. The hardest cases are the cases where the MRI doesn't see an actual lesion, but when we do the biopsy, we find the cancer. That's a little harder because I'm not looking at a discrete nodule. I'm not seeing something, but I know that there's cancer there. So those cases are a little bit harder. And with HIFU or the focal ablation, you may end up treating the whole side of that prostate because you're not exactly sure where the cancer is. So if you can see the lesion on the prostate MRI, then you know where to treat specifically. If you've just done a biopsy and the left side or the right side, only one side comes back with the cancer, and again, we're talking about people who are higher than a Gleason's grade 6, then you have to end up treating that whole side because you don't know exactly where in the prostate that cancer came from. So there is a little bit of art to understanding that and figuring out what the best therapy is for patients. I mean, in my experience, prostate cancer is really one of the only cancers that you can really take your time, because it's slow growing, to go over options with patients and figure out literally what is the best for them for the cancer control and what is the best for them for their quality of life. So let's talk about the focal ablation strategies. So again, there's HIFU, there's cryotherapy, photodynamic therapy, laser therapy, irreversible electroporation, radiation, nanoparticles, and radiofrequency ablation, which is more like microwave. So this is kind of going through all of these treatments. So if you look at this graph right here, for cryotherapy, patients have a continence rate, which is no leaking, of about 89 to 100%. But the erectile dysfunction rate is still 0 to 42%. So it's a pretty big spread. But they usually have very little downtime and rarely need inpatient stays. For HIFU, so cryotherapy is freezing technique. For HIFU, this is thermal energy. So it's an ultrasound that vibrates 10,000 times more than a normal ultrasound was, creating heat that then destroys the tissue, that the prostate cancer tissue. Now, for those patients, about the same continence rate, 85 to 100%, and erectile dysfunction, 11 to 45%. Now, I know what patients will ask me, why is the erectile dysfunction rate still so high? Because when they looked at these numbers and did these studies, they took all comers. So if you came in with erectile dysfunction, it wasn't going to get better with any of the treatments that you had. So if those patients were already automatically in that erectile dysfunction rate at 45%. So these, again, were all comers that they were taking. Now, laser, so the laser was done in an MRI machine. This did not gain a lot of popularity, to be honest. one of the reasons why is that it was somewhat difficult to do, and the patient had to be in the MRI machine for hours, and that was relatively uncomfortable. So it was incredibly time consuming. So for urologists, it never caught on popularity because it just wasn't feasible to do. And again, there were very minimal studies that were done in that. So that's why the continence rate was not recorded. Photodynamic therapy. So you basically inject something into the prostate and then hit it with a beam of light, and that causes that to heat up and cause oxidative stress to the cancer tissues. And that's what really photodynamic therapy was. Again, this was somewhat a little bit difficult to do because if you didn't know where the lesion was or you weren't sure where to inject, it became harder for urologists, I think, to figure that out. So it didn't gain that much popularity, but we still use it for other different types of cancers. Reversible electroporation. So that is basically where you almost use an electric instead of an ultrasound pulse. You use an electric pulse to heat the tissue and cause necrosis or death of the cancer tissue. And again, that was a very limited experience. Now, those patients were done through the urethra, through the P channel. Then you have brachytherapy, which is what we put the seeds in. And then you have radiofrequency ablation, which is microwave, where it causes DNA disruption, and that causes the cancer cells to die. But again, there was limited data on how patients did after those surgeries as far as their continence and their erectile dysfunction. So there have been a lot of different focal ablation strategies over the years, but I really find that HIFU, cryo, and the TULSA have been the ones that have caught on because they're relatively easier to do, and you're still accomplishing the same goals, and the patients have the most minimal downside from having them. I mean, HIFU even much so less than cryotherapy. So who is a good candidate for HIFU? Again, I want a patient that has low-grade Gleason 6 or Gleason 7 lesions. And this is just, again, the prostate grade, the pathology grading system. Depending on how big the prostate is, there was the first machines they came out with was called the Sonoblade. The newest machine they've come out with is the Focal One. So you can get into further reach places with the Focal One. And this is also has the ability to use a robotic arm to help you plan out where you need to do your surgery. And then it delivers the actual high frequency ultrasound ablation. You want to make sure that patients don't have any calcifications within the prostate or rectal wall. Oftentimes, men will have little tiny calcifications within the prostate itself, and you can actually see these on ultrasound or CAT scan or MRI. I often will see them on ultrasound when I'm doing the biopsy. So if a man has very large calcifications within the meat of the prostate, they are not a good candidate for HIFU. The other thing is that if you've had brachytherapy before, you're also not a good candidate for HIFU. But if you've had radiation therapy of the prostate and the cancer comes back, you can still do HIFU on that patient. So again, who can have focal therapy? You want to keep these to patients who have low-grade prostate cancers, PSAs less than 10, Gleason's 7 or less, or what we call grade group 1 and 2, and who do not have a lot of positive biopsy cores. So when we take the biopsies from multiple portions of the prostate, if you have over 50% of the left side and the right side are showing positive for cancer, this may not be the best candidate for a HIFU. And again, these are the American Urologic Association recommendation as well as the European Urologic Association recommendations. Now, it doesn't mean you can't do it. It just means that it wouldn't be recommended for those patients that have a lot of disease within the prostate itself. So who are patients who absolutely cannot get HIFU? Again, if the prostates are larger Sometimes you have to trim down the prostate with a TURP or a rotor-rooter before you can do the HIFU. So the size can cause a limitation. Sometimes where the lesion is inside the prostate, if it's very close to the urethra, may not be the best candidates for HIFU. There have been studies where they use hormones to help shrink the prostate before the HIFU. I personally am not a fan of that because I think trying to regulate with androgen deprivation therapy or depleting the patient of the testosterone before you do the HIFU isn't really a great answer. Prostate calcifications. The reasons why these patients are not good candidates is because you can risk creating what's called a rectal fistula, meaning the rectum, which is sitting right next to the prostate, can get merged together and there can be a hole that's created between them, and that's not good. So if I've had a patient with a rectal fistula, I'm definitely not going to offer them HIFU, but that is one of the risks of all of these focal therapies. So how are we looking at HIFU? So here you can see, this is an image, like a sonogram you would get if you were pregnant and looking at your baby. This is very like low power imaging. That's ultrasound. HIFU therapy is 10,000 times more powerful and it has a higher watts. So you can see the watts is 0.02 and here it's 200 watts, which again creates the heat, focuses this ultrasound beam on the prostate, which is right here. And you can see how the beam is getting focused. And then that causes death or necrosis or destruction of the cells and destruction essentially of the tissue. Now, when you do this, the tissue will swell before it dies. So I have to leave catheters in because I don't want the patients to go into retention and not be able to pee. Because again, the tissue will actually swell first and then scar down and shrink down. So this is just kind of emphasizing my point that we talked about earlier. With the low risk patients, you're going to put them on active surveillance. If you have high risk patients, you're going to recommend higher grade treatment. But really the sweet spot is these people who are right in this intermediate risk zone. And you can do whole gland ablations where you actually treat the whole prostate. The interesting thing about that is they are doing some studies now looking at HIFU for BPH, which is benign prostate hyperplasia with no cancer. These are men that will have a lot of urinary symptoms, so they're looking at HIFU to treat BPH. And then you can do focal treatment where you're just treating the lesion. And then when we talk about salvage treatment, these are patients that have had previous prostate cancer treatments like radiation or cryotherapy or even previous HIFU, and you're going back to do it again. So those are some of the things that you can do with focal therapy to retreat patients. So what does the HIFU system look like? So here you can see the patients on their side. And again, just very similar to prostate biopsies, you're actually putting the probe up the bottom. And this is actually the probe that's going to deliver the heat energy. Now over here at where the surgeon is sitting, the surgeon is fusing the ultrasound images that this probe is taking at the same time that they're looking at the MRI so that you can find the lesion. And the computer technology does that for you. So you'll fuse the MRI and the ultrasound, you can find the lesion. And then I program the focal one to deliver the energy in certain areas. And then I watch it as it's delivering that energy. And if I don't like it, or if it's getting too close to the rectum, or there's something that, maybe it's too close to the urethra, I can stop the treatment and then readjust. And the reason why they call it robotic is essentially because this is a robotic arm that goes in and out and turns automatically once I program the machine where I want to deliver the energy. So that's why they call this like a robotic system. But this is what the focal one looked like. Now, before we had this, you basically had to put the MRI up on a screen next to you and guess where you thought the lesion might be on the ultrasound. So the technology here has actually really helped us because it does the fusion for us and helps us figure out where the lesion is. So what do you need to do HIFU? You definitely need an MRI. Again, the one snafu, maybe if you don't find a lesion, but you still find cancer on the prostate, then we may end up treating the entire half a gland. And you basically can load this MRI into the machine. A lot of the doctors now are using what we call UroNav to take the biopsies. So this can record where you took the biopsies on the prostate. So if you have a patient where the MRI doesn't see a lesion, but you want to know where the cancer is, you can use that data that you saved of where you took the biopsies, bring that up on the machine, and then treat that zone. And then again, you're using real-time ultrasound while the probe is inside the patient, so you can edit what the prostate looks like and get it to match with the MRI, which is actually very important because that helps us know where the urethra, where the P channel is, and where the rectum is. And again, this is kind of what we were talking about, how we fuse the different images between the ultrasound and the MRI and the biopsy. So we're using this technology to fuse all these things together so that we can find where the cancer is and target it. So we don't have to treat the whole prostate or do radical surgery. This is an example of what the surgeon is seeing on the console. And so let's say this yellow is the lesion right here. You can see it. And I will show you the outline. This blue line here is the outline of the prostate. So if we know we want to treat this yellow lesion, I can actually take where these white dots are, which is the treatment zone, and move it and conform it to exactly where I want to be. Now here at the bottom is where the rectum is. That's where the probe is. So you want to make sure you keep these white dots away from this rectal edge. And then in here in the middle is the urethra. And so again, you're going to make sure you treatment conform the white dots away from the urethral edge. And you can do this within millimeters of treatment. So it is very, very specific. What are the advantages to using the Focal One machine? Well, there are 8 focal points where you can focus the energy beam. So it has a variable sense along the entire length of the prostate. You can do more than one treatment. You have a very good, depth penetration, which is up to about 40 millimeters or 4 centimeters. You can treat lesions that are very close to the urethra, and you can do faster treatments, and you can treat lesions that you may not be able to see, but would be able to mark them out with the Focal One machine. Okay, let's kind of move on to like the patient journey, like what happens with the patients when you're getting HIFU. So we did the MRI, we did the fusion biopsy, we got the prostate biopsy, and then you're going to do the HIFU treatment. So the treatment may take 1 to 2 hours. It's usually outpatient. You will need a catheter anywhere from 3 to 7 days. I tell patients now I'm getting a little bit bolder about the 7-day rule. I'm moving it to 5 days. But if you remember, when you deliver this treatment, so here's the HIFU machine delivering the energy inside the prostate. Patient has a catheter into their bladder. So here's the bladder. Here is the catheter coming in through the penis. And then this right here is the prostate. And so the HIFU is delivering the energy right into the prostate here. When you do that, it swells. And if it swells, then the patients can't pee. And that's why you actually have to leave the catheter in for multiple days. And I usually sometimes even give steroids. I do give some pain meds, but they really don't ever seem to take them. They just seem to take Tylenol. And for the follow-up, we usually will do a PSA every 3 to 4 months, get an MRI at 1 year, and then you want to repeat their biopsy at least 1 year later. Because unlike radical treatment, there is a much higher rate of not only recurrence, but sometimes you won't actually treat the lesion. So what does it look like on the day of surgery? So again, the patient is on their side. This is the screen that we're seeing here, and this is the probe in the bottom. So why is HIFU so beneficial? So if you looked at the results for HIFU, and we have about 15 years of data. Now, I will admit that not all of that data is from the United States. Some of it is from Brazil and Europe and other places who have been doing HIFU much longer than the Americans have. And we have some limited data on patients that are treated with the focal one. So you can do hemi or focal tissue preserving HIFU up to 95% preservation of potency, meaning if the patient came in with good erectile function, there's a 95% of chance that you will maintain that potency, a 95% pad-free weight, so not using pads at all, not even safety pads, 90% negative biopsy rate for clinically significant disease. So again, after the HIFU, you have to go back and do a biopsy within a year and make sure that you got all the cancer. And in patients that are getting treated who are a Gleason 7 or less, there's a 90% negative biopsy rate for those rebiopsies. So at 1 year, 90% of the patients, 89% of the patients are getting what we call the trifecta. You haven't lost your sexual function. You have 95% have pad-free, you're not incontinent. And when we go back to repeat your biopsy, you're cancer-free. And that's what we call the trifecta. So who's ideal for HIFU? Again, patients that have had MRIs, patients that have focal disease, patients where we get adequate margins, meaning we know we're treating the entire tumor that's in the prostate. And it's really helped kind of streamline this process for us, which is the focal one machine. MRI fusion is often incorporated to HIFU, like we talked about. It really allows the surgeon to see the limits of the prostate and the limits of the lesion. And again, because of this, we change our energy delivery, which can affect the patient's quality of life and return to normal function. So let's look at a couple prospective studies. So these were studies. So here, I want you to look here. This is the ablation modality. This is HIFU. This is cryotherapy. And this is FLA. And then here's the irreversible electroporation and the photodynamic therapy. But remember, there's much less of these studies. And these are like a microwave, like a heat ablation. So I would say that for urologists, cryotherapy is the standard. It has the longest data. It has the best data. And remember, that's freezing of the prostate tissue. So this study by Ahmed here and the study by Guillemeyer are the ones that have been most quoted in our urology literature. One, because they have the most patients. So the risk of a urinary infection is 9%. The risks of not leaking is 97%. The risk of a fistula, which I said is like a connection between the rectum and the prostate, not a good thing, was very low, 0.3% in their patient population. In the Ahmed study, which is also well quoted in our data, there was 18% urinary tract infections, 90% continence, and 25% rate of erectile dysfunction. Now, you have to be very careful because, again, a lot of these studies looked at all comers, meaning patients that didn't have great erectile dysfunction when they came in. And you have to look back at the studies to look at what degree of cancer they actually had. Some of them had very high grade, some of them had low grade. So these are often all comers. Now, if you want to compare that to cryotherapy, the data is pretty similar. You'll see that the participants in here, there was about 300 patients in this study. 100% had, good continence, and 31% had some erectile dysfunction. but a 2% rate of fistula and a 1% rate of urinary retention, meaning not being able to pee. So the data for these focal therapies is generally the same, although for most of my patients, I prefer HIFU to cryotherapy, to be honest, because the Focal One machine has made it so user-friendly for us to deliver the therapy while protecting the important structures like the nerves, the urethra, and the rectum, that I tend to prefer that. Where most of the cryotherapy is done with the doctor sort of estimating where they need to deliver the cryotherapy by the MRI, and then using that data to put the needle in and freeze the prostate. So there is sort of a difference, I think, in my opinion, because the Focal One machine actually gives me more data about where I'm delivering the HIFU. Now, that all being said, why don't more people do HIFU? HIFU is not a perfect therapy. If you looked at the cancer-free rates with cryotherapy versus HIFU, cryotherapy is actually a little bit better than HIFU for getting patients cancer-free. So what I always tell my patients is high risk, high reward. You know, if you want to have all the cancer out and that's what you're going for, you're going to have a radical surgery. But the risks of having complications from that are higher. HIFU, low risk, but you're taking the chance that the cancer may return in 2 to 5 years or may not have been treated to begin with. So that is the very fine line that the patient and the urologist have to walk between the patient's goals for their quality of life and treating the cancer at the same time. HIFU cryo, they'll never be good as radiation or as surgery at treating the cancer. But we know that because many of the prostate cancers are not life-threatening, that you can walk a fine line between that and find some balance for the patient between preserving their quality of life and treatment. Okay, so let's move on to what TULSA Pro is. So again, this is an ultrasound-based energy. Now with the HIFU, you're going through the rectum and delivering the beam through the rectum into the prostate. With TULSA, you're going into the P channel, into the urethra here. You're putting the probe in through the prostate, which is here, into the bladder. And you're using this central area of ultrasound to deliver the heat into the prostate around it. And so it's actually going in through the urethra itself. Now, one of the really exciting features about TULSA that I think is a little bit different than HIFU is you have this endorectal cooling device. So obviously, if you could imagine, when you heat tissues, there are certain tissues you want to heat and kill, and there are certain tissues you want to preserve, which is usually the rectum and the urethra. So using this cooling device, you keep the rectum and urethra cooler, and you just are heating up the prostate tissue. So that lends to better protection from having adverse events. And so that was sort of the benefit of using this device over HIFU. The benefit of HIFU over TULSA ultimately for me is that I have better vision to where I need to treat. And the way the machine works, I can better strategize and tell it exactly where to go to treat the cancer within millimeters. But I think this technology will become more progressive. And I'll tell you, for patients that have had colostomies or their colon or their rectum removed, I can't do a HIFU because there's no place for me to put the machine in. So this ends up being a better option for some of those patients. So now they do have a robotic arm that's part of the TULSA as well. And so it's moving in and out of the urethra, delivering the treatment in certain places. This is the energy system. You do have an MRI because you're actually doing the procedure in an MRI. So this big circle thing right here, this is part of the MRI machine. So this procedure is done in an MRI machine. So you're seeing this live time feed of what you're treating. And then you have the device that goes into the urethra and the device that goes into the rectum, which is the cooling device. So what are the features of TULSA? So you're doing transurethral directional ultrasound ablation. So as it goes into the urethra, it's delivering the heat out. Obviously no incisions, there's no radiation, and there's no energy going through the rectum like HIFU. And one of the most important things is there's no volume limitation, meaning that with HIFU, you can only do prostates of a certain size. Whereas with TULSA, you can do prostates that are very, very large and don't have to do anything preoperatively. I don't know if you remember, I was talking about sometimes you have to do a TURP or a Roto-Rooter before you do the HIFU, and some patients you even have to treat with anti-hormone therapy to shrink the prostate before they're candidates for that procedure. Well, you don't have to worry about that with the TULSA. Again, one of the other benefits about it is the way it delivers the thermal energy is what we call a closed looped system. So the heat can't just go out other places. It's in a very specified area. Whereas with the HIFU, it's kind of going out one directional. And you can keep track of the temperatures of those tissues as well. You also get temperature feedback with the HIFU. So the machine itself can sense the temperatures within the prostate and then adjust itself so it knows if it needs to get cooler or warmer based on what the tissue needs. And then, like I said, the biggest consideration is that the urethra and the rectum are cooled. Now, they are just doing a trial on TULSA, so we don't have all of the data yet on whether continence and erectile dysfunction and cancer control. So that still is coming down the road. But as you can see, it does have some very viable options for patients. And if patients have a really big prostate, the TULSA may be the better way to go from the HIFU. So that will remain to be seen as they get more through the trial itself. And I have a couple of physicians that I work with that have been doing the trial. So this is me, and this is all my fellows here. I don't have any kids, so I always say that these are like my kids. They always come back to see me and visit me in the operating room. And Mom, can you help me with this case? Mom, I need something. So, but we have a really great group. I love working at St. John's. I originally came from University of Arizona. I did my cancer and robotic training at City of Hope, and then I stayed with City of Hope for about 4 years after I finished my training there. And then the chairman of my program, Dr. Tim Wilson, he left City of Hope to come to St. John's, and I followed him out here, and I've been ever since. But I really like working at this hospital. It's a great hospital. Okay, now I will be happy. I'm sorry I talked so much, to take some questions.
Thank you, Doctor. What a delightful presentation. Very, very clear and easy to understand. Ira's got a couple of questions for us. He's wondering if HIFU can be done as a transperineal rather than transrectal.
No, because you'd have to deliver the energy some way, and you're not going to open up the perineum to get the probe in there. In that sense, you would be wanting to do the TULSA because the urethra, the probe would be going through the urethra and delivering the energy to the prostate that way. But there's no way to do it without having an orifice open for the delivery of the energy system. So you have to essentially do it through the rectum.
Same thing with TULSA as well.
Yeah, same thing with the TULSA. Has to go in the urethra or it has to go in the rectum. You can do cryotherapy perineal. You can do seeds perineal. You can do photodynamic therapy through perineal. Anything that you can do with an injection, you can do perineal. So the cryotherapy, again, a lot of that is just a needle in, and the needle gets cold, treats the tissue, and then you pull the needle out. But these two therapies, not yet.
And Ira also wants to know, what if you have multiple sites of cancer in the prostate? how does that affect cure where HIFU is concerned or where TULSA is concerned?
So first you have to figure out what the biopsy grade is in those different areas. So do you have a 7, do you have an 8 and a 6? You're probably not going to treat the 6, but you're going to treat the 7 and the 8. Now, when you're talking about, well, how good is the therapy at treating the 7 and the 8? The therapy's not that great at treating the 8. We know that because when they did some of the original studies with the HIFU treatments, and again, this was not with the focal one, this was before that time, patients had Gleason's grade 8, over 30% of them recurred within several years. Okay, that's why the AUA and the European Association didn't recommend that you treat that stage cancer. But if you have a Gleason 7, those patients have 80-90% cancer-free rate, so it was better at treating the lower grade lesions. I hope that answered your question.
Bob wants to know if you can access a lymph node from an orifice, can you treat lymph nodes that are affected by METs?
So, not yet, but that kind of technology is coming where we actually have a small robot. It's not prime time yet, that it can go in through the rectum and get out into the tissues where the nodes are. Now, you can't keep the rectum intact and treat the nodes with just an energy beam yet. You're not quite there because there's going to be a lot of important stuff in the way, mostly the blood vessels that you don't want to injure. But we will have a therapy where you could open up the wall of the rectum, get out, treat the node, and come back in a sense. So, and we call that natural orifice surgery. But we don't have anything yet that you could focus a beam so precise through the rectum that it would just treat like 1 or 2 nodes that you were aiming for without hurting the other structures in the way.
And if you do an MRI and biopsy after a year, how do you monitor? You do an MRI and biopsy after a year. After that, how do you monitor the cancer?
So I'm probably a little conservative. I usually will make the patient get another biopsy in a year. And if 2 years have gone by with no cancer, then I'm like, okay, we can just watch your PSA.
Okay.
And I think most urologists, even for active surveillance, feel the same way. If you have 2 negative biopsies, then, we can just watch your PSA at that point.
This is an interesting question from Ira. Are you doing any work with PSMA MRI directed focals?
I am not. I know that I have a couple of friends from UCLA that are working on technology like that. I think the thought is that you have the PSMA scan. The PSMA PET picks up where the lesion is, right? And then you would actually have a technology that could direct the energy to where that pickup of that signal was, right? But I am not specifically doing any of that work just yet. I mean, I think the PSMA scans, though, I will tell you, every year, we're getting closer to using them more diagnostic, meaning finding prostate cancers, than just using them to follow patients who already have metastatic disease. So right now, if you wanted to get a PSMA PET scan, you would have to have metastatic disease. I can't be like, I wonder if you have prostate cancer, let's get a PSMA PET scan. Oh, I can order that, but insurance won't pay for it. Right now, that's mostly for patients where we're like, okay, you had treatment, now your PSA is going up, and now we're going to do the PSMA PET scan. So, but I think all of that technology, every year, it's really gaining.
Serenity wants to know, what is the clue that the PSA is too high? that the cancer has come back? What is that PSA? I guess what Serenity is looking for is a specific PSA number. And my question would be, is it just the PSA, or are you looking at other things as well?
Well, so there's different scenarios. So I have patients who have PSAs that are as high as 32 who do not have cancer. They've always had big prostates. They always have had high PSAs. They've had 5 biopsies. They don't have cancer. I also have patients that have tiny little prostates, chock full of cancer. And I have patients with PSAs of less than 1 who have prostate cancer. So I always tell my patients, I don't really care about a number. There's not like some magic number. What I care about is a trend, which is why I still think checking the PSA is so important, because unless you check it, you can't establish a trend. So if I have a patient that has a PSA of 1 and the next year their PSA is 3, that's kind of alarming to me. If I have a PSA of 32 and his PSA the next year is 33, it's not alarming to me. I mean, he lives at that level, normally. So it's more about the trend. Now, if you've had a patient who has had treatment, they've had treatment, then you have to worry also about the PSA going up. If you have your prostate removed, the PSA should go to 0 and should stay at 0. If it trends up over 0.2, we start to get a little bit worried that things are coming back. And sometimes we'll just kind of watch it and see what happens. If you have radiation, the PSA will drop to some finite number, meaning that it doesn't always go to 0. So some patients will have radiation and the PSA will go down to like 1. Well, what do urologists can then consider recurrence? The PSA has to go up 2 more than the lowest it has ever gone, which would be 3 or above 3, more than on 2 labs, and that would be considered recurrence. So PSA is always, it's just never been a great way to follow anything. It's really about the trend and less about the exact number. I hope that answered your question.
Neil, I have a question.
Go right ahead, please.
Hi, Dr. Linehan. This is Dr. Metzger. Thank you so much for a very complete talk. This was great. We really appreciated being in Santa Monica and putting up with Tim Wilson is probably enough of a chore for you. But when Tim was with us, he used to come to our library sessions once every other month for, we'd review the literature. Then they'd stay and play poker. And he may be a world-class surgeon, but boy, he sure can't play poker.
Can I tell him that?
You can. He used to wear 2 or 3 shirts because he was always losing his shirt when he played with us. And so, yeah, you tell him that, and he'll laugh. I had a question there, a comment, and it's not about. We've had quite a bit of luck with the TULSA Pro in some of our men. We haven't had too much experience with HIFU in the cancer forum, but we keep reading about the micro 29 megahertz ultrasound coming out. And do you think that's going to change the ability to do a targeted biopsy without an MRI and push it back into the office where it really belongs?
That is a good question. So if you're going to push it back into the office where it belongs, that means all of us again have to relearn ultrasound and what lesions look like on ultrasounds. So the answer is yes, but you have to have urologists who are willing enough to go out, take the courses, do the studies, see what lesions look like, and able to perform the ultrasound and read the ultrasound well enough to get as precise as what the MRI is.
Do you think it's going to be helpful or be just another big roadblock? We're having trouble getting the private guys to do MRI fused biopsies. I just wonder how this is going to work when the radiologists, second opinion radiology reports are often different. You get a bunch of urologists that are not trained, and it could be interesting, but it's coming.
Yeah, no, that's what I said. I mean, you have to have people that are dedicated to go taking the ultrasound courses and reading the ultrasounds. I mean, we did a lot of that when we were in training, and then the MRI came out and we kind of got lazy about it because then the radiologists were reading. And you're right. I have patients who have MRIs at St. John's, at UCLA, at different places, and all the different doctors read them differently.
Sure. Well, the pathologists we always ask people to get second opinions there because it often gets changed. And that's one of the reasons that 3+3 got overtreated was because it was being overread, underread, or who knows what read. But you can't seem to get two guys to agree on it. I think Ira's question about PSMA, is there ever going to be a chance where that's going to replace MRI or micro ultrasound?
Yeah, I think that that's a very good chance that that will replace MRI because, I mean, even with lesions, PIRADS lesions, the highest grade lesion that the radiologist can give it based on the diffusion or how the lesion is picking up and getting rid of the contrast, is still, up to 60% of those patients don't actually have prostate cancer. So I think the PSMA is going to be more specific, in the end at finding the prostate cancer than the MRI. But you're going to lose, I think, some with a PSMA scan, you lose some of the anatomical evaluation of the prostate, I think, with that. Like, for example, it may show you that the lesion's close to the capsule, but the MRI might even be able to distinguish how close or if it's even through the capsule. Whereas I don't know if PSMA will be that precise, like millimeter precise anatomically.
Good. Well, again, once again, thank you very much for a really wonderful talk. We appreciate your taking the time.
Absolutely. I've got another question from Bob. If PSA goes above 0.2 post-surgery, what do you recommend and at what PSA level? I guess we're looking at PSA levels a lot tonight rather than additional indicators in addition to PSA.
Yeah, I mean, I think these are hard questions because what we used to do is if your PSA popped up above 0.2, you got radiation after surgery. So if you had your prostate out, then the PSA went up above 0.2, people automatically shuttled you to radiation. And now I think we're realizing that may not be the right thing to do. That may have been ultra overkill. So a lot of times we'll watch the PSA and see if it goes up again. Maybe it's going to get to 0.2 and that's where it's going to stay. Then you don't need radiation. But if it keeps jumping up at a higher rate, especially it's jumping every 3 or less months, so to speak, the velocity that it's jumping up is going to help you make the decision on whether this patient needs more treatment. So again, I think like when I was in training, the thought was 0.2, as soon as it gets to 0.2, you better get that patient radiation. People aren't doing that. Urologists aren't doing that anymore because radiation in itself has a lot of complications. But if you see someone who's like 0.2, 0.6, 1, then you're probably going to recommend treatment. There was a study that was done very early on that demonstrated that patients who had PSAs over 0.2 had better recurrence-free survival if they got radiation right away, or a second or what we call a salvage treatment. But that data has changed because I think there was a lot of people that went to 0.2, went to 0.4, even to 1, and then the PSA stopped going up. And so maybe there was some benign prostate tissue left there. So that's changing. So I generally tend to watch the patients before and see how fast the PSA is jumping up before I commit them to a secondary therapy.
Excellent. Ira, if you unmute yourself and could you ask your question about the study about PSA by Donato?
I read a study by Dr. Donato, and he within the prostate, he measured, PSMA versus, the MRI, and the PSMA found, a bunch of stuff the MRI didn't, and vice versa. Approximately 98% of the prostate was identified. This was done a couple of years ago. Just mentioning that.
So that the PSMA found more things than the MRI.
Yeah, it found things that the MRI didn't, and there was a few things the MRI found that the PSMA did. In total, virtually all of the prostate was identified.
Yeah, no, that's why I said I think that PSMA is going to end up be more specific for finding cancers, more sensitive for finding cancers. But I think you're going to miss some of the anatomical evaluation that the MRI gives you. I don't know, maybe one day there'll be like a PET MRI scan. It'll be like some kind of combo scan where you have the PSMA plus the MRI.
By the way, I like to mention I don't have any metastasis. I'm on active surveillance, and I just had a PSMA which was covered by Medicare. So I don't think you have to have meds to have a PSMA.
What's your PSA level?
6.7.
Oh, that's very
So
interesting.
I think I read the literature that said that.
Yeah, I think that's changing. Well, it depends on the patient's insurance. I've had a bit of difficulty trying to get PSMA pre-treatment. Like, okay, we've done the biopsy. I know
This
that
is
there's
not
cancer
treatment.
there.
This is simply the test I'm talking about.
Right. That's what I'm saying. I've had difficulty getting the PSMAs if someone's on active surveillance or pre-treatment. Like, let's say I think they need treatment,
Right.
and I want to know if there's lymph node metastasis. But it's very insurance dependent. Medicare tends to be the most generous of all of them, but for some of these younger guys who don't have Medicare and private insurance, it's a big pain in the tush.
Yeah, I'm simply mentioning it to you, so you might want to look into it.
Okay, great. I will. Well, I think they're going to be changing the guidelines again this year so that the PSMA scans are much more inclusive.
Outstanding. Does anybody else have questions that we can direct to the doctor? Well, I want to thank you for your time tonight. And also, as long as we're dropping names at St. John's, we very much enjoyed David L. Krasny. I hope I'm pronouncing his name right. K-R-A.
Yep.
Did I pronounce it right?
Yeah.
Okay, we very much enjoyed his presentation, Pathology of Prostate Cancer. We haven't seen him since 2018. He can jump on Zoom. He doesn't have to come out here all the way to the church anymore. So we very much enjoyed him as well. And I thank you for a wonderful, straightforward, easy to follow presentation, perfect for a patient audience. And I urge all of you who are watching this on YouTube to please check out our website at prostateforum.org and learn how we can help you with support groups as well as more presentations like the one you're watching, how you can make donations, and how you can volunteer. I wish all of you a wonderful evening, and we'll see you again in a couple of weeks for support.
Thank you, guys. Really nice to meet all of you. Thank you so much.
Thank you.
Thumbs up.
Thank you.
Thank you.
Thank
Bye,
you.
guys.